All right, good morning, everyone. Welcome to another session of the YOF Educational Forum. Today's session is a continuation of last week's session. So we're going to be continuing with Retinal Optic Coherence Tomography course by the Retinal Fellow from Eye Foundation Hospital Group and Kunle Hassan Eye Foundation Academy, Dr. Umeh Victor Chukwebuka. My name is Dr. Rodia Shodonke. So he will continue, but we stopped last time at pathology. So he's going to continue. He may just do maybe a brief summary, just to let some of us catch up, and then go ahead with the rest of the presentation. If you have any questions, you can drop them in the chat box, and then we'll take everything at the end. Thank you. Okay, Dr. Umeh, you have the floor.
Okay. Thank you, Dr. Shodonke. Good morning, everyone, and thank you, YLF, for having me again today. So we'll be taking the abnormalities part of the retinal OCT. There's so much to cover in a short while, but I hope and I'm looking forward that it will be worth our time. Okay. So this was a synopsis from last week. From our learning objectives from last week, we've been able to describe the normal retinal anatomy on OCT, and I described and also mentioned the significance of the layers. So today we're going to the objective number 3, 4, and 5. So as a refresher, I'm moving down to the normal OCT printouts so that from there we'll get to. So this printout is the consensus, is the international nomenclature for retinal OCT. And I'm going to point to the different layers here. So you either go from in to out or from out to in. So this is the vitreous, is the posterior cortical vitreous. The space in between is the pre-retinal space. This fine hyperreflective area is the ILM. So sometimes you have to look closely to see it, but it's almost always there, except if peeled during a macular hole surgery or membranectomy and ILM peeling for other retinal pathologies, especially diabetic retinopathy. Now, this is the nerve fiber layer, which I mentioned last week, that on macular OCT, the nerve fiber layer is thicker on the side of the eye of interest. So this is a right eye. So if you didn't see this and you have just the macular OCT, looking at the nerve fiber layer thickness discrepancy between the right and the left will tell you the eye. So the next layer is the ganglion cell layer. After that is the inner plexiform. After that, we have the inner nucleus. I said that when we get to these neurosensory retinal layers, there are alternating bands of hyper and hypo reflective areas once you are moving out from the outer nucleus upwards. So the nerve fiber layer is more hyper reflective than the ganglion cell layer now, and then the inner plexiform layer is more hyper reflective than the inner nuclear layer. The outer plexiform layer is more hyper-reflective than the outer nuclear layer, which at the foveola, this layer is the Henle fibers because of their arrangement and their number. So we get to the photoreceptor and RPE area. The first hyper-reflective band is the external limiting membrane, which I'm pointing out now. The next is the myoid zone that contains ribosomes and granules of sugar. Now, after that zone, we have the ellipsoid zone, which contains most of the mitochondria of the photoreceptor tissue. So these areas, the myoid and the ellipsoids, are part of the photoreceptor tissue. Now, you now have the the outer segment of the photoreceptors, which is this hypophotoreceptor reflective band that I'm pointing out now. The next area is the hyperreflective band, which is the interdigitation zone. After that, you have the RPE and Brooks complex. That's from the that's the O for the neurosensory retina and the RPE. The next part is the choriocapillaris. We remember from theory, choriocapillaris, it's fenestrated, it's closer to the Brooks and allows for the passage of nutrients to the photoreceptor cell and the outer 1/3 of the neurosensory retina. The other layers are choroidal, the layers of the smaller vessels, the medium-sized vessel, that's the sasla, and the bigger, that's the ala. So, bearing this in mind, we'll now go to the abnormalities, and I want us to think along what is normal while thinking about what is abnormal. So for abnormalities, the consideration we have to look at is the location of the abnormality. Now, is the location of the neurosensory retinal tissue or interface where the abnormality occurs, the size of the abnormality, the shape, and the thickness of the retinal layer of interest at that point. The reflectivity of the structure being that you're using a laser light. So if you didn't get what we said last week, in OCT, the term is reflectivity. It's either hyperreflective or hyporeflective. So that's the term used for OCT. Now, with that, would have a histologic correlation of the abnormality with the patient complaints. And then we are guided by the history and the examination finding to reach a diagnosis. A lot of OCT features actually are not definitive diagnosis, they point to differentials. What makes the diagnosis is your examination findings and the history. So a patient with diabetic retinopathy could have tractional membranes, could have epiretinal membranes. And a patient with long-standing uveitis could also have epiretinal membranes. So seeing epiretinal membranes is not the diagnosis. The diagnosis is based on the patient complaint and your examination findings. The investigation adds, the OCT investigation adds to it. It doesn't take preeminence. So if someone sends you an OCT and you say, this is epiretinal membrane, that's it. But the question is, what is the cause? And that's you have to answer. So we're going to start with the vitreoretinal interface disorders. These are disorders that occur between the interface between the vitreous and the retinal. So the settings are usually settings of partial or complete vitreous detachment with or without retinal tissue distortion. So let's go. We'll go through VMA, VMT, and macular hole. So this is the first. So this is a vitreomacular adhesion. Note that the OCT was taken right at the center. Okay? And if you remember our layers again, this is the vitreous. Okay? This is the preretinal space here. Now, this patient has already started having some form of posterior vitreous detachment, but the vitreous is still adherent at the macula. But as we can see, the foveal depression is still intact. So this is a vitreomacular adhesion. Okay, so I've put this so that it would help with the explanation beyond what I've just said. Partial PVT, thin vitreous adhesion at the macula. Foveal contour is unperturbed. There are other features here, but that's not what we are looking at for now. So this is a vitreomacular adhesion. So this patient may have, you should be expecting someone around the 50s to 60 presenting with, some may have complaint of floaters, some may have complaint of flashes. because of the tug here, but they may not have a metamorphoxia or micropsia because the macula is intact. So, and this patient too, if you do your waxing out lens sign on the slit lamp, you won't get that result of a broken line. So this is an adhesion, okay? Vitromacular adhesion is at the interface between the vitreous and the macula. Now, I know most of us would have noted the difference between, most of us would have noted the difference between the first image and this second image. Now, I'll point out the difference here. This is the vitreous, the posterior hyaloid. This is the macula. If you look carefully, the foveal depression is lost. So the macula is pulled upward. And you can see that we have some intraretinal hyporeflective spaces. And that's because of the disturbance of the foveal contour. So this is vitromacular traction. So there is a traction ongoing. So this patient will most likely have much more of flashes and floaters than the patient with vitromacular adhesion. So in this instance, the other neurosensory retinal layers below, this is the ellipsoid, this is the external limiting, this is the interdigitation, this is the Brooks, they are intact. So, and the outer nuclear layer represented as the Henle's fibers here are still intact, except some part of it has been pulled up, okay, creating this space here. So this is vitromacular traction. The difference between traction and adhesion is foveal contour disturbances. That's the difference. So this is another OCT, prominent vitreous adhesion in the macula. That's one part. Distorted foveal contour. That's it. It's meant, we are meant to have a depression down in, but it's distorted, and you have these hyporeflective spaces here. Okay. Now the treatment differs. Sometimes this can be observed for a complete PVD to occur, which if it occurs, you could have a resolution of the fovea going back to normal. Or with this, it can progress to formation of a macular hole because of the traction. So the decision is dependent on the ophthalmologist, either to observe or to intervene. The thought of you can intervene and induce the hole yourself if you are not very skilled with macular surgeries, but you never go wrong with observing, except if the person already has a full thickness macular hole in the other eye from the same, then you weigh your chances. Now, this is a macular hole. This is actually a patient I know quite well. So I'm going to describe what has happened here. So let's start with the left eye. In the left eye, you can see that there is a full thickness break in the macula. The retinal layers are retracted to the left and to the right, and there is a space in between them. The only histologic marker available at the macula is the RPA, which I'm pointing out now. So if we measure the size of this hole, it qualifies for the grade 4 hole by gas classification. And also there are hyporeflective intraretinal spaces which occurred because of the traction and the foveal distortion. Now, to the right eye, now we could see. So the macular hole is the retinal break at the macula, and it's usually true and true. If you look closely, you would see that although there is a cover upwards here, the biomarkers, the lines of the outer retina have been distorted in this eye. So you have the RPE is standing. There is a break in both the interdigitation, the ellipsoid, the myoid, and the external limiting membrane. So this hole may actually be smaller compared to this. On the OCT machine, you can put your calipers and measure. And if it's less than the 400 microns, it could be between 100 to 200 microns. You start thinking, oh, this is my grade 1 or grade 2 hole, okay? And here, there is already a complete PVD here, okay? Yes. So this is also a place to take a note at the EDTRS map here below. So if you judge that whenever you see a red that is a macular edema, you would have called this a macular edema, but that's not what it is. There's increased thickness in the macula, but that is because of the cystic spaces. However, we know that there was a traction that was released and there is a break in the retinal layers. So this is a macular hole, and this is also a macular hole, but this is more advanced in staging than this. This is stage 4, this is between stage 1 and stage 2. So this, the right eye, I just brought it out for emphasis. So the layers are distorted, the RPE is continuous. So you have a full break. This outer layer around the ILM is still standing, but you already have a full break here, okay? Okay, so anyone can actually pick this up. This is a macular hole. The layers are distorted. This is post-surgically. The patient had an ILM peeling. This is the ILM here. ILM peeling and inversion over the hole. This is 2 months after the surgery. You will watch that this layer is the external limiting membrane. It has reconstituted. The ellipsoid is reconstituting, but there is still a defect here. The RP is continuous, the interdigitation is still reconstitution, but there is still some defect here. But the visual acuity here has improved compared to this. This was around the 636, and this is around a 618 on pinhole, then 624 on aided, okay? Yes. So there are studies that have shown that this ellipsoid line here and the external limiting membrane are key for vision after macular surgeries. So those are what the surgeon uses to assess. So this is also an example of using OCT for monitoring. Pre-surgery, post-surgery, you look out for the differences in the histologic layers. Okay, so I'd wanted to say, let's take a guess, but would have a chorus answer, but I'll point out some things. If you think that this is a macular hole, you may actually be correct. But if you check out the layers, you see that external limiting membrane is intact, ellipsoid is intact, digitation is intact. This is a shadow from here. And the RPE layer is also intact. So, but the outer nuclear layer, which is the Henle here, has been distorted and you have hyporeflective spaces. So if a hole does not go through and through, it's a lamella. So it means it has occurred in a part of the macula, a lamella of the neurosensory retina, and in this case, just the outer nuclear, okay? All right. So I've mentioned the VMA, which you have adhesion of the vitreous, strong adhesion of the vitreous to the macula, but foveal contour is undisturbed. The VMT, where the foveal contour is disturbed, but there are no breaks in the layer, but you could have hyporeflective spaces. Breaks in the macula, where you have the macular hole, different types, different sizes. And then the lamellar hole, where a lamella of the neurosensory retina is affected, but the others are spared. So epiretinal membrane is seen as a hyperreflective band over the surface of the neurosensory retina. Usually it occurs, when it happens, it creates some corrugations on the surface of the neurosensory retina, meaning they are not as flat as they should be, and you have some form of corrugations. I'm going to show that. This usually happens after a PVD because it allows room for glial cells and myofibroblasts to proliferate over the surface of the neurosensory retina. So I'll show you this. This is a patient with, this is an epiretinal membrane. The differentials are quite a lot: diabetic retinopathy, posterior uveitis. It also happen in those with sickle cell retinopathy and all. So the surface of the retina is no longer flat. These are the corrugations. I'm pointing them out. These undulations are because of the effect of the epiretinal membrane. It's exerting some form of traction around it. See, the foveal contour also has been disturbed. Now, this is the same patient after surgery. The surgery is PPV, pars plana vitrectomy with membrane peeling. Okay, the membrane has been peeled and the patient is getting some form of resolution. This shiny membrane has been removed. Okay. Now, so I've talked about the vitreoretinal interface disorders. Now we're going to talk about the neurosensory retinal abnormalities. So like I said, everything you see is a feature, and it still boils down to having differentials. Key word is differentials. What brings the diagnosis is your history, your examination. Is a non-diabetic of 20 years, a non-hypertensive patient of 10 years, not a non-hypertensive, not a non-diabetic, is 40 years old, type A personality, previous history of helicopter pylori. Those adds to pointing to a definite diagnosis. Okay, so let me start with the most common. This is macular edema. So if you have this OCT, this is a printout of an actual patient. This patient has multiple intraretinal hyporeflective spaces. Okay, if you look, you may be able to detect the line I'm pointing to now is hyperreflective line. That's the ellipsoid. The interdigitation zone is not well shown here, but the RPE is standing and the ELM. Now we go to the EDTRS map and we'll check the foveal, the EDTRS map, and you see that the thickness of the foveal region is 570. The parafoveal region, you have 427, 497, 535, 523. The perifoveal the same. So this color code map would give you a red color once the thickness goes to the range in red. If it is white, it means that the thickness is in the regions of 700 and above. Okay. Now, this is macular edema. The cause could be anything. It could be diabetic, it could be post-traumatic, it could be post-cataract surgery, it could be anything. Okay. So the history is what makes the difference. Macular edema secondary to complicated cataract surgery. Macular edema secondary to, or diabetic macular edema, that one has a definite name, or macular edema in a non-sickle cell retinopathy patient. So you take that down. So I'll show you this. So I'm bringing this in here because it's a case of monitoring, treatment and monitoring. So I'm going to use this EDTRS map to show us a few things. Now, this is the scan at different times while the patient was on treatment. And I think I'll say this, that if you're going to take care of a patient appropriately, even if they present with their own OCT scan and your consultant is going to treat and you're going to be part of the team, it's important that the OCT is repeated with your own machine. That's because if you do that, the algorithms of the machines may actually differ. So you can't say, oh, foveal thickness is 500, and with the test the patient came with and you start treating. And when you're done treating, you give intravitreal injection, or you give topical, or you give intravitreal implant of dexamethasone, Osidex, or whatsoever, or you decide it's small, let's observe. You need to know the exact foveal thickness with your own machine, because that will be the baseline of checking whether the patient is getting better or getting worse. So for this patient, if you look closely, you see the dates of the scan. This is 15th of February 2021. The foveal thickness here was 543. This patient got anti-VEGF, and by the next time he was seen, the foveal thickness had reduced. So if you look closely to where I'm pointing, you see minus 35, you see minus 48. So the algorithm will keep comparing the next scan to the previous scan, to the previous scan, to the previous scan. So if you follow this and come to the map I'm showing you now there, this is a foveal thickness map, this is a macular volume map. This was the foveal thickness at this point, the first one. When it was checked again, it has reduced. So the map went downwards. By the time this patient presented again around August, this was June, skip July, presented in August, the foveal thickness had increased. So in reference to this, you have an increase of 23. This is a plus 23, means fluid have reaccumulated here, and this compared to this is a plus of 23. So the map here goes up. Look at it here, okay? Now, subsequently, the patient got an intravitreal dexamethasone implant, and after that, the scan done 2 months later, you see a sharp decline in foveal thickness, and it's pointed out. And if you look at the map, you see minus 296. So the foveal thickness reduced by 296. And if you look at this map representing it, you would see that the color code on this map, the central fovea has changed to green. So you have green moving all over. This is the color code. It's just that if the foveal thickness is reducing to this range, it will be in green. So some persons will use color code and tell you, once you have green at the fovea and the parafoveal areas, your treatment is working. But if you look at this retinal map here, you see that there are no intraretinal cystic spaces in these two maps here. There are here, there are here, there are here. So this patient, after this time, 11th, this November, he's seen in January. When he's seen in January, you have some reaccumulation of fluid, okay? So you now see the foveal thickness is now at minus 98 compared to minus 298. And see the map has gone up. So you see, you scan, you check the map, you check the retina after you've checked the patient. So at this point, at the start, the patient's vision was 624. At this point, his vision was 69. At this point, his vision was 69 only on pinhole and 612 unaided. At this point, his vision has gone back to 69. So this is an issue of monitoring. I know Dr. Abdul would have shown this for optic nerve head, where you follow the changes in the nerve fiber thickness. For the macula, you use the map, you use the graph, and the feature of the OCT printout. So I've pointed this out. I think it should be well understood now. Okay, so this is a patient. I can give you a few history about this patient. This a 20-year-old myopia since childhood, and his refractions were -15 with a -5 cylinder at axis of 75. So what you have here is chiasis. There is a pulling away in the neurosensory retina. The outer lines are preserved. The neurosensory retina layer where this occurs differs. In this patient, this is the outer nuclear layer. Usually there are types of schiasis, foveal schiasis or retinal schiasis, but this is at the macula, okay? So when you see this, you tally it with the history of the patient. I know on fundoscopy, you have something like a bicycle wheel appearance, but you put all those things together, the patient being a myope may have collagen disorders, maybe mafanoid and all. So this is a schiasis, okay? It's not a macular edema, because if you put a map, if they have put the EDTRS map beside it, definitely it will be in red, but that's not. You look, the fine lines here shows you that there is a pulling away. It's not fluid accumulation. This is a better illustration of the fine lines. That's why I left it here. Okay, all right. So I want us to look at this, and let me see. If anybody can volunteer to make a comment on this, I'll really be glad. Then I'll tell you what it is. Anyone on the chat, or you can unmute, just make a comment. What do you think? What do you see? Don't give a diagnosis, but just say what you can see. That's all. Anyone? Just tell me the abnormality you can see on the scan. What is abnormal? That's all.
Well, Dr. I can see that the central fovea is well, in the first scan that you are showing,
yes, sir.
There's alteration of the foveal depression.
Okay, that's correct.
So it's almost flattened. And if I can see very well inferiorly, as if is this separation of a bit elevation of the retina from the RPE, right?
Yes.
At the periphery. So
okay. Yes.
Then the epiretina, the ILM.
Yes.
Looks off. Irregular. Okay. There's retinal membrane actually in the first photo.
Okay.
Yeah, all right. I can see the retinal membrane.
Okay. Okay. Thank you, sir. Does any other person want to make a contribution? Actually, on this, there's no right or wrong answer. That's why I just tell me the abnormality you see. That's it. What is abnormal? And maybe let's focus on this map that I'm pointing out now, the lower one. What's abnormal? Okay, there's a chart. Let me see. Here, neurosensory retinal detachment in the inferior hemiretina. Dr. Idris, I didn't ask you. Okay, so.
Good morning, sir.
Good morning. Go ahead.
Dr. Sukoya. So I just want to give it a trial, sir. In the lower picture you showed to the left, the surface of the the retinal surface is corrugated. That's
Correct.
yes. Then so it's not smooth as we should
Okay.
see.
Okay.
Then so to the right, besides the separation of the neurosensory retina, there is also fine hyporeflectivity. Now I'm not
Yes.
fluid accumulation or if it's the macula, no, if it's maybe retinal schisis that you just explained, but that's what I can see, sir.
Okay, thank you. You were correct. Everybody was correct, actually. So if I put everything together, I will tell you about this patient. So this is a 56-year-old known diabetic presenting with blurring of vision of 2 weeks duration, accompanied with flashes and floaters and veil-like obscuration of the vision in the superior field. So I've just told you about this patient. What the patient presents, this is a separation of the neurosensory retina away from the RPE. You have some hyporeflective intraretinal spaces. You have an epiretinal membrane giving this corrugation here. So this patient had an inferior retinal detachment in addition to fractional retinal membranes on fundus photo. So this is an inferior ROD in a known diabetic. So you can understand the membranes, the corrugation, and the retinal detachment. So in this eye, you may see no hole. So it's a fractional retinal detachment, and it was inferior. Okay. Let me see. Okay, there is a message here. ALM distortion. Okay, it's not schisis, please. In schisis, you would have wide spaces and you see the fine lines, okay? And with the history, I think you know it's not schisis. So this is an inferior ROD. So on the macular map, you may see this and say, oh, it's edema to one side. No, the separation is the neurosensory retina is pulled from the RPE. So it was an inferior ROD. So usually when you scan, the first scan here is from left to right. So it will not show this. This scan is from up, down. So it will show this. So on this scan, this is left, this is right. On this scan, this is up, this is down, okay? All right. Thank you for contributing. Thank you, everybody. Now, there are a host of abnormalities in this scan. We've moved from the intraretinal, the neurosensory retina to the outer retinal area now. There are other things that could happen in the neurosensory retina. There could be accumulations of fluid, accumulations of exudates, and all, okay? I'm just taking the common ones so that we can go through and everybody will have a good view of what we're talking about. So here, there are many things happening. And if you have a scan like this, a host of differentials come into play. So your history and examination will be the key to your differentials. But I'm going to point out a few things for us to see. Okay, now here, the neurosensory retina is detached from the RPE, okay? Here, the RPE is detached from the choriocapillaris. This is the RPE line, okay? This is the RPE line. So this is what we call a PED. This is a PED, but this is a serous form of retinal detachment. This hyporeflective space here most times contains fluid, will contain blood as well if it's hemorrhagic, okay? Now, let's go through these ones and I'll show you. This ARMD, And of course, you can see drusen. I'll show you drusen, but these are drusen. But when when we say the drusen, when they coalesce, they give you a PED. Okay, this is the fundus photo. So this person had a fundus photo, and then had an OCT, had an FA. This is an FWACS imaging of this. So you see these bumps on the road here. Okay, so this drusen, large drusen, large drusen. The key word is location. They are below the RPE. They are basal laminar drusens and all. They are below the RPE. And you can see that the RPE is thrown into folds. It's corrugated rather than flat. The ellipsoid line also follow the contour, the same for the ELM, okay? So this is a 56-year-old female presenting with reduction in vision of about 2 years duration. Not a known diabetic, not a known hypertensive. She's Caucasian and she's a smoker and has been smoking since she was 18 years old. Okay, now there are other things to look out for, but what we have here is a serous PED. This is a big one, and you can see that there are also some hyporeflective spaces under the neurosensory, between the neurosensory retina and the RPE. So you adjust this and then decide, oh, what's going on here? If it's ARMD, is this wet? Is this dry? Okay. Now, dry, you have just drusens. When you start having hemorrhagic PEDs and all, you've moved into wet because there should be a neovascular membrane somewhere. Although they are thought to also be part of those that have pachychoroid diseases, meaning the choroid is the choroidal vessel, the large ones and the medial ones are enlarged and leaky, meaning blood leaks across the choroidal capillaries and gets to them, to the RPE, okay? Now, this is a geographical atrophy, and I want to explain a few things here using the OCT. Geographical atrophy does not just mean the RPE. It means the area of interest from RPE down. So it could affect the RPE, affect the neurosensory retina, affect the choriocapillaris, causes it to become thinned out, okay? So I'll point out things on the OCT here. This fundus photo, this FA, this is FA, this an FWACS image. So I point this, see the yellow lines, the yellow arrows. The yellow arrows are showing you the abrupt stop of your ILM, of your ELM, ellipsoid, and RPE. So from this point into the fovea and to this edge, there are no RPE lines, there are no ELM lines, and there are no ellipsoid lines. So the atrophy is geographical. This white arrow is pointing to atrophy of the choriocapillaris. The area is too thin compared to what it should be. And if you look here, the Henle layer here is also thinned out. So what you have here is a geographical atrophy. And I'll show you, I'll point out something of interest that you should also look out for. There is an excessive hyperreflectivity in this place I'm pointing at. Now, see this region I'm pointing at, pointing downwards. It's because of the atrophy. It's called a reverse shadowing. Reverse shadowing. Shadowing is that if you keep a tall person in front of a short person and take a picture, you won't see the short person. Reverse is that, oh, instead of the area being covered and dark, it's now excessively shiny. It's shiny because the laser light penetrates deeper than it should because the RPE is thinned out and the other layers below it is thinned out. Okay. In FFA, we call it a window defect. The window being the RPE window is open, so you could see the underlying hyperfluorescence of the choroidal vessels, okay? And that's what it's here. All right. So this is a wet AMD. So I know it's wet AMD because I know the history and everything, but I'll show you on the OCT. On this is a representation of the EDTRS map. You see this area that is in red. There is some retinal thickening going on there, okay? And it's not in the fovea. It's actually between the para and the perifovea. So this is the OCT. Now I'll show you a few things and then I'll show this. Where I'm pointing at now is the neovascular complex. This is the neovascular membrane that has caused this increased thickness seen here. And if you look, you see that the RPE is pulled up and down, is distorted, and there are some shadowing here. This dark point, this and this, because of the neovascular membrane. And if you go all the other way, you see that the RPE is thrown into corrugations. This is by drusen. What you have here is drusen. Okay, they've thrown these areas into corrugation. So this thickening here is from the neovascular complex, the neovascular membrane in a wet ARMD. Okay, so I've left this image here to ask what we think about the OCT on the left eye. Okay, but I'll just go through it. What I want us to look out for is that there are no drusens. There are no fine elevations of the RPE by hyperreflective material. Let me move back. This elevation of the RPE here is by hyperreflective materials. Let me go back again. The drusens are relatively hyperreflective. They are hyperreflective because of their contents. Now you have this big dome-shaped PED, that's pigment epithelial detachment. No drusens. This way too, no drusens. This is a 56-year-old male. Okay? So looking at this, you already have differentials in your mind, but one of the differentials that you will not entertain in this man is ARMD, because if you're seeing him, if you look at an eye that doesn't have drusen and does not represent an OCT, you put in your other differentials, other forms of pachychoroid diseases. You think about PCV. Is this PCV? Is this CSR? CSR would have been more on the center, central serous. This is not central, okay? Now, okay, although this is not part of our discussion, I brought it in. This is an OCT angiography of the same patient, A superficial layer. Okay, the vascular layers of the retina are represented on the angiography. This is the superficial here, and you can see the FAZ. This is the deeper layer, and you can see this is the outer retina. You can see the mosaic pattern that you have here is no longer here. The outer retina is distorted. That's why you have these dark spaces because of the PED. In the choriocapillaries, you'd have the mosaic pattern is also poor. but you have some areas of burdens around these areas that I'm pointing out. And when you get to the emphasized image of this, you see these buds here. Okay, these round budded areas. So with mentioning the buds, I think we've gotten to a diagnosis if you are the one seeing this patient. So this is a polypoidal choroidal vasculopathy in this patient, bringing about this serous retinal detachment away from the macula, more away from the central. So you can call this central serous retinopathy, chorioretinopathy, okay? All right. Okay, so this is another image, but I think the FA has given it away as it is. This is a different, this is the FFA, the hyperfluorescence that we report as ink dots, blood, smokestack. This is the ink dot stage on FFA. The smokestack is when you have a release, a lot of release through the RPE breaks and all. So this person have a serous retinal detachment. There's a small PED here, but this was more of a CSR than a polypoidal choroidal vasculopathy. The black arrow is pointing to thinned choriocapillaries. This big arrow. Okay, so what we have here is enhanced depth imaging, OCT EDI, enhanced depth imaging. So the large choroidal vessels here are dilated. They are big. See the hollow. See the hollow. See the hollow. So this part of a pachychoroidal disease. Pachy means thickened. It's thickened because the vascular layer dilated. So it leaks fluids and blood across the thin choriocapillaries to the sub-retinal space. Here also note that the RPE is intact for most of the journey, okay? This is just the one. This is also a difference, could be also a difference between PCV and CSR, okay? All right then. So I'll leave this and ask someone to just tell us what you can see. And I'll tell you where to focus on. Focus on the outer retina, RPE segment of the outer retina, and compare the left to the right and tell me what you can see really. Any volunteer? I'm putting my arrow on where you should check. Here, all the way to this side, and compare it to here, all the way to this side. I think volunteers that have not spoken before, please. Any? You can send a chat, or you can unmute and contribute. Please feel free. And as I will say again, there's no right or wrong answer. It's what can you see? Okay, maybe I should select a volunteer. Okay. Anybody, please.
Maybe some people are having difficulty with their network.
Networks.
It
Okay.
keeps ejecting and adding people. But we can see thickening of the choroid, dilated vessels, and some hyperreflectivity.
Okay. All right. Okay.
Then,
Thank you.
in addition, Dr. Victor,
Yes.
in the left eye, the
Yes.
RP and the interdigitation lines seem discontinuous.
Yes.
And there are some small corrugations or distortions I can see in the outer retina in that left eye, and then the medium vessels seems dilated in the choroid,
Okay.
with some shadowing.
Okay. Thank you, sir. So I would point this out. If you look at this right eye, you look at the outer retinal lines. I'll point them out. This is your RPE and Bruce complex. This is the ellipsoid, and this is the ELM. If you come here, it's difficult to make out those lines. You can say, oh, this is RPE. Oh, there is no lines representing the ellipsoid. The ELM is not clearly defined, and you have this hyper-reflective form of some of accumulations. Yes, and there are these shadowings here, reverse shadowing. That's because those lines are not there, so light passes through so much. Yes, you can say, oh, there are some form of dilations of these vessels here, but in this case, not so much. Okay, so I'll give you the history of this patient and I'll let you know what the issue is. This is a 30-year-old female presenting with poor night vision of about 3 years duration and similar history of poor night vision in older siblings. Okay, now you already started thinking, where are the rods? Where are the cones? Where are they represented? So a study has shown that this is part of the histological pattern in patients with RP. The next picture I want to show you is the fundus. This is the fundus photo of this patient. Although this is not so clear, these are bone speckled pigmentations. And I'll bring back the OCT again. This is the OCT. Note that in this OCT, I want to also point out something. This cross here is actually meant to be in this center. Look at it. So if I was there at the time of the scanning, it would have been rescanned. This line should cross here, not here. But you also know this patient may actually have fixation issues. Okay. So this is a patient with retinitis pigmentosa. One of the studies I was involved in checked the lines in patients with retinitis pigmentosa on OCT and found out that the lines were reduced or missing out entirely. Okay, that's what I just mentioned, and it affected their vision. When you have those lines, vision is better, even if the patient has a lot of bone speckle pigmentation. But if the lines are absent and you have few bone speckles, the vision goes down. So if you're monitoring a patient with RP, you should have an OCT, and it's your basis for prognosis and for counseling. Now, when you monitor, if you did an OCT, vision is 6-9 daytime, and you have an OCT, the lines are there, and 2 years down the line, you repeated the OCT, the lines are beginning to reduce. They will shrink before they disappear. You counsel the patient about the disease and what he or she needs to do before vision goes down entirely. Vocational rehabilitation and all, including the lights, and then trial of vitamin A, and give them hope, because research will soon have a breakthrough for us to move ahead. So we've used almost all our time, but I'll point out a few more things, then we go. So this patient has RPE atrophy. If you look, the RPE is reduced, but if you look, you see that the other lines are also distorted. ELM distorted, ellipsoid distorted, okay? Now, in this patient, you have an ellipsoid loss. This hypo-reflective spot here is an ellipsoid loss, okay? So, in conclusion, the other thing we have to watch out for is artifacts during the OCT scan. They affect the quality of your scan and they reduce what you actually get back, okay? So artifacts could come from both the patient, the machine, the operator, the positioning of the patient, and all. These are some common ones. If the pupil is poorly dilated, you have the laser light being blocked. You can have mirror artifacts in people that have long eyeballs. It means you have to move the machine closer. So the image may become inverted instead of being what it is meant to be. So misalignment means that the fixation is not on the fovea. So the image may give you something wrong, okay? So the other artifact is blink. If the person blinks, you will see a dark band over the OCT, and it's usually true and true, just showing that there was no capture at that point. So, and if you have, there are places where they have out of range errors because it came at so close to image, and then some part of the OCT is cut off. Then segmentation errors means that the lines are not fixed. So there are two lines that every machine tries to fix in order to make their calculation. They put a line on the ILM and put a line on the RPE. Those two lines are used as landmarks to count the retinal thickness. Imagine if those lines are farther away from where they are meant to be or too close, you'll have a wrong calculation. Then other practical sources of artifacts, excuse me, if you have media opacities, it will affect the quality. You see that your signal strength is low, is poor. If you have a corneal opacity, a cataract, vitreous opacity, pre-retinal hemorrhages will cover the area entirely, especially if they are dense. And the same for FFA. Other things you could see is silicone oil can come up as an artifact in patients that had vitrectomy with silicone oil. Air will give you a dark band over the area of the OCT. The image could be inverted. So, and those that have nystagmus, you see multiple motion defects. Parkinson's, multiple motion defects. When you position the patient poorly, your patient is following if patient follows the fixation light while it is going, you could actually have two foveas on the same scan. Okay, this is a patient with myopia. You see the eyeball is long and pouched out, and then while trying to scan this eye, you have something like a mirror image here. It's an artifact. The patient moved and the machine was moved closer. Now, in this patient, you've lost this side of the scan, and that's because the pupil was small. So something is clearer here and is lost on this side. Pupil was small and is blocking the light. There's a misalignment here. This is the fovea, but the technician scanned where he could scan. So you have your fovea on the side. So this is a misalignment, okay? Now this is a blink artifact. Blink artifact is like, how do I put it? It's like losing a match. It's zero. So the dark band goes all the way through the OCT, all the way. This blink. But for motion, it segments. This is an emphased image. See this retinal vessel. It comes here. It didn't continue from where it's meant to continue. It segments and it segments. So this is out of range. The other part is not cut. So this is a combination of this is the motion artifact. You have a dip into the retina. This is the blink artifact, darkness true and true. All right, so thank you for your time, and I'm open to questions and contribution. Thank you. All right.
Thank you so much, Dr. Umeh. I noticed that Dr. Shodunke, Dr. Nurat are not with us. Okay, Mr. Chairman, you want to say something? Welcome aboard.
Just to say good morning, Dr. Umeh.
Good morning, sir.
Thank you. Just to say thank you for keeping us, what do I say, keeping us glued to our sets for the past 2 weeks. This second week going. We've learned so much from your wealth of knowledge. And be sure to know that your people and our solidaries will want some more one of these days. Look forward to meeting in Lagos next week. Thank you so much.
Thank you, sir. Thank you. I'm most grateful for the privilege. Thank you.
Thank you, Mr. Chairman. Now the floor is open for questions, contributions, comments. We'll restrict it to 3 to 5 because we have already passed the time limit. So can we take 3 questions, contributions, clarifications? You can type in the chat box. And as the chair said, please we encourage members to participate at the YF session that will take place on 1st September. And we have some round discussion, God willing, on scholarship and fellowship applications, opportunities available that some people may not be aware, so that people can have their hands on them. Then there will also be election of new escorts for the YF. So YF are going there. We will recognize some of our active members and contributors to the association and give them awards. So we hope you will join us on 1st at Nnamdi Azikiwe Hall, Radisson Blue Hotel. Okay, we have the first question here. Can you see it, Dr. Umeh?
Question is there a way to differentiate between dracenoid from hemorrhagic PED on OCT? Yes. Yes. So the dracenoid PED, the dracene itself is a bit hyper-reflective. Okay. The hemorrhagic PEDs are not hyper-reflective, they are hypo. You see this white dome of RPE elevation. Also, if the patient is someone you've been following up for a while, your OCT will show you when you have drusen in the patient, and you see and repeat your scan, you see that the drusen is getting bigger. When they coalesce, you see that dome, but it's much more hyper-reflective. But when it is hemorrhagic, it's usually bigger. The hemorrhagic PED is usually larger and is hyporeflective. Okay, yes. So that's a clue to differentiate the two.
All right. I'm afraid that's all we can take. That's the only question for the day. Thank you so much for the session. We appreciate your kind contribution to the fortnight academic session. This is not the first time. Thank you so much.
Thank you, sir. Thank you for having me. Thank you.
Okay, thank you all for coming. We will share the recording very soon with those that couldn't join. Yeah. All right, bye.